Hi there, this is Aaron Filler, and I'm a neurosurgeon in Santa Monica, California, affiliated with Cedars-Sinai Medical Center. And I want to introduce the section of the textbook related to peripheral nerve disorders and peripheral nerve surgery. And in doing so, I want to just credit and acknowledge as well my co-editors for the section, Alan Belsberg from Johns Hopkins University, Martin Malaysi from Leiden University in the Netherlands, Liang Chen from Huasheng Hospital and Fudan University in Shanghai, China, Holly Gilmer from Beaumont Hospital in Royal Oaks, Michigan, and Mark Mahan from the University of Utah, Salt Lake City. So as an overview, this section of the Humans and Women Neurological Surgery textbook dealing with peripheral nerve disorders and peripheral nerve surgery includes 20 chapters. The first of these, chapter 26, concerns positioning, and the remaining chapters run from number 270, this overview, through 289. We cover in these chapters the pathophysiology of surgical nerve disorders, details of the peripheral nerve exam, peripheral neuropathies, which are helpful to be aware of in distinguishing from surgical disorders, monitoring, electromyography, evoked potentials, imaging such as magnetic resonance neurography and diffusion tensor imaging as it applies to peripheral nerve. Then we go through different regions of the body and classes of common surgical problems, including a chapter on distal entrapments such as cubital tunnel, tarsal tunnel, peroneal nerve entrapment at the knee, carpal tunnel, also more proximally brachial plexus entrapments and thoracic outlet syndrome, for the pelvis, piriformis syndrome, and pudendal nerve entrapments. Also, we then discuss nerve repair. This includes not only techniques for nerve repair and reconstruction, but methodology, a chapter on nerve transfers, a chapter on how to evaluate and consider the timing for nerve repair, secondary procedures for the brachial plexus injuries, such as joint fusions and other methods of optimizing function in the case of an irreparable brachial plexus injury, nerve injuries of the lower extremities, nerve tumors, and then discussion of how to avoid nerve injuries during surgery, and then for advanced technology, a treatment of neuroelectronic systems, the sort of Luke Skywalker hand technology that allows for patients requiring distal amputation of the forearm, for instance, to have the nerve elements brought out to muscle, and then using electronic pickups to determine which muscle the nervous system is trying to operate in order to assemble these and to operate some robotics. And then a coverage of different types of stimulators that are used with peripheral nerve to affect central nervous system and autonomic disorders. Now, overall, we can divide this overview into a discussion of both the general areas of discussion, the important controversies in peripheral nerve surgery, and important advances. So the overview deals with the role of imaging in peripheral nerve treatment, such as magnetic resonance neurography and peripheral nerve DTI, as I mentioned, minimal access approaches. So there's a transition going on within peripheral nerve surgery from a class of approaches which was extensive, that is a larger incision, allowing for detailed electrodiagnostic evaluation of nerve injuries and extensive repair, versus a new class of surgeries with minimal access approach that rely on preoperative MR neurography, for instance, to identify precisely what needs to be done to target exactly where the incision and approach should go to minimize the exposure, treatments for piriformis syndrome, and how to recognize this to distinguish piriformis syndromes from sciatica due to, for instance, herniated lumbar discs. Management of pudendal nerve entrapments, which can be confused with cauda equina syndromes because you can have a nerve entrapment resulting in genital area numbness, incontinence, and other symptoms that most concern most neurosurgeons when they develop in the setting of a cauda equina compression, although this is a distal nerve entrapment. The role of endoscopy in peripheral nerve surgery, and the use of MRI-guided procedures to carry out hyaluronidase enzyme neuroplasty or nerve release using genetically engineered enzymes to release nerve entrapment rather than open surgery. As just mentioned, we'll cover advances such as the success with neuroelectronic prostheses, as opposed to joint fusions and tendon transfers for management of difficult brachial plexus and upper extremity nerve entrapments and injuries, severe injuries, and then controversies such as the role of outcomes research in, for instance, ulnar nerve neuroplasty in situ versus transposition, the timing of nerve repair and severe trauma, the use of autograft versus synthetics for repair, neurectomy versus neuroplasty for problems such as occipital neuralgia, and touching on two of these in particular here at this slide. Timing of nerve repair and severe trauma is really an area that there's considerable change because the classic teaching was based on, in part, not having imaging, so that when a severe injury occurred, we wanted to wait both to see if the problem would resolve on its own, and then if there was a severed nerve or irreparably damaged nerve, to allow for scar tissue formation to complete, and then proceed with surgery to remove the scar back to fresh tissue, and then place a nerve graft. And often these surgeries would take place in the range of 4 to 6 months after the injury. And now we understand that when the surgery can be done early, more within the first few weeks or month or so, the chances of recovery, successful growth of nerve is dramatically increased, so that there's been a real shift in timing for nerve repair, and particularly with the availability of advanced imaging to provide a very detailed characterization of the injury prior to the surgery in order to optimize planning. The issue of neurectomy versus neuroplasty, really that neuroplasty, particularly even an injection neuroplasty, can often relieve an entrapment. And neurectomy, however, is something that can't be undone. And when a painful neuroma results, then these can be very difficult to treat. And so neurectomy is rarely recommended. The use of autograft versus synthetics is an area where improving synthetic tubes to bridge gaps may result in as good or better recovery than the use of grafts, so that there's a diminishing role for nerve grafts. At the same time, very elaborate use of nerve grafts for end to side type nerve transfers, borrowing segments of nerve from one distal nerve tree to use for a different function when the original nerve cannot be restored for use. All these are covered in the various chapters. So although these various topics are covered in detail in the chapters and in the various PowerPoints that go with the chapters, here we're giving this overview of how some of these different advances and controversies play out. One of these would be in the pathophysiology of thoracic outlet syndrome. So to one extent, we have surgeons who express a belief that the condition doesn't exist. And this is often a matter of either the lack of training in residency, so that a surgeon follows a methodological approach that they learned 30 or 40 years in the past, versus using the new level of technology to see exactly what the issues are. So, for instance, a thoracic outlet syndrome with a lower trunk pattern of lower trunk of the brachial plexus pattern of nerve entrapment affecting, for instance, fourth and fifth digit numbness, along with both a weakness in the thenar and hypothenar eminence, so that it really can't be a strict ulnar nerve entrapment peripherally, with sensitivity over the scalene muscles, and then having an image, a neurography image that will show the lower trunk specifically impinged and distorted, then a post-op set, for instance, in image C and D here, showing that once the neuroplasty and scalene muscle resection has been carried out, the entrapment is resolved. It matches the contralateral side, and the symptoms are resolved. So this really isn't a matter of belief. It's a matter of direct observation, and increasingly these issues are also addressed by more elaborate formal studies, such as outcome trials based on formal prospective trials of high quality study design. Another way that nerve imaging has affected our understanding of even very common problems such as carpal tunnel syndrome is shown by this image pair, where in the upper image we see the median nerve as a set of fascicles anteriorly within the carpal tunnel with the tendons dorsal to it, and then another wrist image below where the median nerve is dorsal to the tendons rather than ventral to them. So this is the same individual, just simply who's asymptomatic, simply flexing and extending the wrist, and we see that the nerve typically moves. And what can happen is a carpal tunnel syndrome in which there's no real physical compression of the median nerve, but it's adherent to the ventral aspect of the carpal tunnel so that it does not move normally with wrist flexion and extension. This is another way in which imaging can give tremendous insight into what we would otherwise take for granted in a mental construct of what the pathology is, when imaging can reveal the actual pathologic physiology. Now, earlier I touched on this issue of understanding an injury early on in order to make the appropriate decisions. The neurography image in the upper panel here, panel A, demonstrates a severe brachial plexus injury from a motorcycle accident where the shoulder is driven down and the clavicle compresses and disrupts the upper trunk of the brachial plexus, crushing it between clavicle and first rib, leading to a fully segmented broken nerve. And there's really no reason to wait to see if this is going to recover, because the nerve is severed and it's not going to recover on its own. The middle and lower trunk, if they are symptomatic, might recover, but a meningocele is seen, indicating that the lower trunk is very likely disconnected with an avulsion, although the presence of a pseudomeningocele does not prove avulsion of the nerve root from the spinal cord. But the length of tissue that would need to be grafted is apparent, and given the difficulty of getting a good result for brachial plexus, it makes more sense to make a generous resection, place the nerve graft, and then if there's ineffective transition progress of the regrowing nerve through the graft, to consider a late repair or optimization. But if it can be properly anticipated, then getting the nerve repair regrowth process started within the first few weeks after injury is very beneficial to the likelihood of a successful income. By contrast, in the image B below, we see a nerve root that has clearly been completely avulsed from the spinal cord, which can be confirmed by other studies, in which case there's no need to wait to see if it's going to regrow. It's obviously not going to. And even the scar tissue issue is not the same as it might be if this were a crush injury in the portion of the nerve at this level marked as LT with the arrow, because other strategies are going to be needed if any reanimation, reinnervation is going to be accomplished. And this is an image that shows how nerve imaging can be used to assess what is taking place when a nerve graft does not seem to be resulting in proper growth. That is, no evidence of reinnervation change, no progressing Tinel sign. An image may reveal the presence of a neuroma formation at the coaptation point with no neural tissue crossing the gap. In this case, there clearly will be an indication to go back, resect the areas of scar formation, bridge the gap either with a synthetic tube or with autograft, and the basis for this failure should be apparent within 2 to 3 months without waiting for a full 6 months to elapse even to start the attempt to restore function by grafting. The use of nerve imaging also can reveal other types of phenomena that were not well understood. Here is an example of a severed sciatic nerve wherein the patient developed restored function of flexion at the knee. The images demonstrate that, for instance, in image C, the hyperintensity is still present in the biceps short head and in the semitendinosus, but that the biceps femoris long head is now returning to normal appearance, and the reason is shown in panel A, that there's actually a neurite outgrowth from the stump that's reinnervated the muscle and restored function. So this kind of detailed analytic understanding of recovery is very important, as it might certainly change the plan as to any sort of reconstruction of function. So one of the important advances in peripheral nerve surgery is the use of intubulation guides for repair, that is, using this type of synthetic tube rather than using an autograft, though these can be used along with autograft. What's done here is to use sutures to tie the peripheral proximal stump to the tube at one end, and then similarly to secure the distal stump to the other end of the segment of tube. And then as nerve regrowth occurs, the neurites exit the proximal terminus, travel along the tube, and then enter the distal stump. And so we have an exit from a primary source and one entry, whereas when graft is placed, the neurites have to first exit the proximal stump, enter the graft, and then exit the graft, and then enter the distal nerve element. So there are 4 transitions instead of 2. The intubulation material also is very efficient at excluding scar tissue, which can intervene and make the transit of the neurite outgrowth more difficult. It also helps keep growth factors close to the area of growth. Overall, the result has been that in many cases, excellent result can be obtained without use of an autograft, so that intubulation guides are increasingly quite important in the setting of the need for nerve repair. Among the most interesting developments in peripheral nerve surgery is the development of eloquent neuroelectronic prostheses, particularly for the hand. And these are used in settings where either an amputation is required or when it's not possible to even consider the use of nerve grafting to try to get a distal repair. Any sort of distal repair for hand function is quite difficult because the long distance nerves have to grow. And so the result here, which is to provide a fairly usable hand, is preferable to some of the low yield or low success methodology that has been tried in the past for distal brachial plexus injury repair, where reanimation of the hand is an objective. The way this works is that the peripheral nerve, such as the median nerve and the radial nerve, may be separated into some of its fascicles, and these are led to muscle groups, and then the innervation into the proximal muscle is used to generate a signal so that when the brain attempts some movement, the peripheral nerve activates, and this triggers an EMG detectable response in a patch of muscle. We then use pickups to detect the EMG activity. This identifies which nerve is being fired, and then a computer or included microprocessor can use that information to direct the hand robotics to respond in a way that the person intended with the nerve activity. Now, the process of learning to use these it requires quite a bit of training and practice, but in the correct situations, this has proved to be a much better solution than the simpler, older prostheses, or in some cases a better choice than an attempt at reanimation with nerve transfers and nerve grafts. Another level of advance in this particular problem of reanimating the distal hand has been the introduction of inductive coil technology, which is a coil that can be placed around the proximal stump, and the coil can be used to deliver electrical power into implanted myoelectric sensors, so that these sensors can be implanted. There's no need to have EMG electrodes on the surface. In fact, nothing needs to actually go through the skin. So the myoelectric sensors are implanted near the sites where nerve endings have been led to. They can be powered through inductive power delivery from the coil, and at the same time, the coil can detect the labeled output from the different electrodes in order to detect the person's intention for movement. So with all these considerations, advances in imaging, advances in neuroelectronic prostheses, new synthetic graft techniques, and also a variety of advances in the biochemical field of understanding the nerve growth factors, together with higher level surgical issues of advances in minimal access approaches, MRI guided approaches, the use of enzymes for neuroplasty rather than direct mechanical neuroplasty, as well as providing a detailed understanding of how to approach nerve injuries, identify them, and plan which technologies and methodologies will be most appropriate, are laid out in detail in these 20 chapters about peripheral nerve pathology and peripheral nerve treatment. Thanks.